Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Joe Gagnon, CEO at 1upHealth. Joe, welcome to the show.
Matt, so much appreciate you having me on. Thanks for doing this.
So, Joe, what I always like to do before getting into the main part of my discussion is to give my guests a chance to provide more of an introduction in terms of who they are and what they do. So, Joe, the floor is yours.
All right. This is a long story. We'll make it short. But my first job out of college was working at Presbyterian Medical Center. We worked on, it was a while ago, of course, a chart tracking system for the director of medical records. And the only thing that I got actually out of that experience, because I was quite frustrated, was I married the girl who was the director of medical records. And so this is like my start in healthcare. So I lived a life with a registered record administrator, ICD-9, ICD-10, DRGs, coding optimization, paper records, microfiche, microfilm, all of the things that here we are 30 years later, and we're just starting to get at. And so I then spent a good part of my career working on, we'll call it tech-enabled transformation of other industries, retail, financial services, travel, transportation, all the things that we've benefited from the early days of the web, all the way through to the social world that we live in today, and the positive impacts that that's had on our lives. Yet, healthcare is still operating as though we have, the doctor, the primary care doctor showing up your house with a buck, with their bag, trying to remember who you are. And it just became sort of a frustration for me over time, which is, can we bring, sort of the same basic concepts of, how to use data, how to use technology to benefit all of us on the most important topic of our lives, which is our health. And so now 4 years now with 1upHealth, working to build this data platform, which we'll talk about, to help the industry operate better, get to the world where those beautiful doctors and nurses can do the magical work that they can do, and the system doesn't get in the way.
Yeah. So kind of given that premise, then, what are you focusing on at this moment in time from that technology perspective to hopefully further drive and encourage effective utilization of technology in healthcare?
Yeah. I think that every business, has a set of processes that somewhat organically grew over time. They weren't designed, right? So we had stuff happen with Medicare. We had employer payments. We had fee for service. We had a ton of different shifts and changes. We had the Affordable Care Act, and we had the Cures Act. And all of these were somewhat independently designed that didn't work really cooperatively to a world where the systems today are sort of out of alignment. And so how we think about this is then you sort of have to step back and say, well, what's the foundation of improvement? And the foundation of improvement always is sort of the utility or the infrastructure on top of which everything operates. We can go back to the interstate highway system, right? Facilitated commerce. The railway system with its standards facilitated the movement of, people and packages around the world. And similarly, the internet has done that, and cloud computing has done that. But we haven't been able to effectively apply that to healthcare because of all of these sort of disjointed designs that weren't really designed together. And so to actually get to the good place that we want to get to, we believe that using the existing cloud technology, we can build infrastructure that will allow all those processes to sit on top of, sharing information effectively, and then leveraging, all of these different assets better than they are today, because today they're just not well connected.
Yeah, so kind of to that point, and as you pointed out, you have this kind of gradual implementation and adoption of laws that each take a different approach. And then as you were also just saying, you're taking the available technology to layer on top of that and kind of build the bridges. What are the bridges that you're currently working on that are bringing those disparate pieces together?
Yeah, it's a great question. We often complain about the federal government and all the burden it puts on us. But in this case, the group, the Center for Medicare and Medicaid Services, CMS, who pays for, Medicare and Medicaid for all of us, through both taxes we take and the money that the government has. And they have said that they want better connectivity across their partners. So the payers for Medicare Advantage, the ACOs, these provider-payer relationships about risk and quality and, basically better care, excuse me, they are saying to us that we need to have a data standard so that all of these businesses can operate in near real time, sharing the information each of them needs so they can operate their business better. And so the FHIR data standard, which HL7 developed, CMS adopted and said, we're going to use this as the beginning part of being able to move data between a payer and a provider, between the payer and the patient, and to allow us to then start to harmonize the processes, because we've defined that care and risk and quality matter, but you need data to make them work better. And so CMS has now said with its mandates that you are going to need to adopt this cloud-based FHIR standard. You're going to be able to share data and you're all going to work together. And we're early in this journey, but we're seeing some progress.
Yeah. So, and I guess maybe taking a step back, and this will be me displaying my lack of very fine technical detail, but kind of what is that data standard, and what, and how does that demonstrate its importance?
Yeah. So the way that systems, everyone builds a database, and in the database you define a set of fields, and everyone can define the fields that they want if you do that independently. But there are core data fields, that the federal government and this HL7, this quasi-government organization, have defined that all matter to all of us. And it could be patient name and address. It could be other resource types like medications and others that we've talked about from a billing point of view. And so I have one standard, even though it's not perfect, a canonical data model that says, here are the definitions for each of these data types, these resource types. And then instead of building something separate, they said there's a technology platform, JSON, JavaScript object notation within the internet world, which is what we use on our phone all the time, we just don't know it, is the technology to put that canonical data model in. And so then presumably what you'd be able to do is you would send a FHIR data packet to someone else and they would be able to then read that. It's the same idea as, what happened with the euro in Europe. When there were a lot of different currencies, you have to translate the currency one to another. But with the euro, the same in currency, it all communicates and works well. And that's what FHIR is intending to do for all of us. There's still some work to do because as you implement, you learn some of the weaknesses of it. But the strength is that we've made a decision on FHIR as the data standard across healthcare. And that's just great.
Yeah, and that statement obviously is going to make me focus on what are the weaknesses that have been found so far, and what steps do you think will be kind of necessary to help address and improve on those areas?
Yeah, there's with anything, until something is used, you never know its strength or its weakness. Actually, in the design, I don't care what you build, from a car to a blender, you have to build a prototype and try it to see if it actually works as you thought it would. And so with FHIR, there are some uniquenesses in the ways that a payer or a provider would represent some data elements. So these resource types have some implementation details that we're now defining that say, oh, okay, if you're going to use, I don't know, let's call it first name, last name, here's the number of characters, here's the way you represent that. In addition, the implementation guides tell you how to implement that so that, this is the Da Vinci group. They've been defining this here's this sort of abstract model, then how do you actually go implement that to make sure that we all implement it in the same way? And then, as it relates to new and emerging ideas like, the data quality standards that NCQA stands for, you would then say, oh, what are the data elements that I need to run a quality measure? Were those included in the canonical data model? And you're like, oh, maybe they weren't. And then you might say in a specific area like oncology, maybe there are more data fields that we need to define. So it started at the more administrative level, and now it's growing beyond that. But as long as it keeps coming back to the standard model, that's where we make the changes, and any exceptions are documented. We have a higher probability of this data actually being able to interoperate. I mean, we've talked about interoperability for, God knows, 25 years. But, a fax, I guess, is interoperable, right? It's just not computable. So you can share a fax because we have a standard. But once you get it, you can't do anything with it. And so here what we're trying to do is create interoperability that allows you to compute on that data, not just share the data.
Yeah, and to that last point, as you said, if we're trying to drive interoperability that you can compute upon, where do we stand in terms of progress on that front?
Well, we are, early, let's say, in this journey. It was 2020 when CMS said, we're going to use the patient access API to actually require that any federally regulated payer has to make their claims data available to their members through an API with no effort, right? And, well, there hasn't been a lot of access to claims data since then. It's not because the data has not been converted and available. It's sort of a little bit of, well, we really never told the member. Not sure we gave them the application that made it easy to do that. And so that on one level, the data access down to the consumer level, well, we got some modest progress, but what we did get was a lot of implementation of data converted to FHIR. The usage now is going to start to move in this direction, Matt, which is this next set of regulations require payers to communicate with each other. So share payer-to-payer data, so the claims data with each other historically. Then you also have the provider being able to access the claims data. You then have the requirement soon that prior authorization data would be available through an app. So you'd know what got approved, what data was needed, why it wasn't approved. You'd have some historical stuff. And so all of this data is now going to start to be available in FHIR. So now what happens is, okay, we're moving that data. Now you would say, oh, this is really interesting because I now have this emerging longitudinal patient record where I'm starting to see historically something about a patient because they might have been part of 4 other health plans. What if I go and get through treatment, payment, and operations some of the EMR data, and I can combine that together in FHIR because that's available in FHIR. You now start to see that the completeness of a patient, so Joe or Matt, we might see your whole history as available. Now with that data, you can imagine all the things you can compute on that. You can come up with better care plans because you actually know sort of the historical view of patients that look like us. You could do better risk assessment because you would know the history of a patient. You would actually be able to do, better quality measures because you'd be able to do them in real time. And so that computability, it's not that we don't compute today. We're just computing on a very limited data set that does not have the kind of currency and comprehensiveness that we need to make better decisions. And so that's the direction we're moving now.
Yeah, and that's I think, as you said, being able to form a more complete picture of an individual to drive better care direction and kind of treatment interactions. One would hope that would resonate with everybody, but maybe to be slightly cynical, you could also see business cases or strategic business reasons why maybe some would drag their feet on that front, because they could potentially view it as losing market share.
Yeah. So the practicality of life here, right? There are a lot of embedded self-interests in every system. We won't indict healthcare particularly any more than any other system. But the medium to longer term, the short term, yes, getting change to happen is hard. You're taking something away, you're giving something to some, but ultimately medium to long term, the benefit of data sharing, of transparency, of this very contemporary experience that we've gotten used to, is beneficial to all of us. Matt, the bottom line is, look, at $4.5 trillion of spend, almost 18% of GDP, we get the least amount of return for the spend that we have in healthcare in the country. I think Congress is growing tired of that. Members and patients are growing tired of that. Yes, there are some corporate entities who appreciate that they get a lot of profit from the way the system runs today. But long term, that just cannot sustain. We can't go to 25% of GDP if we put inflation on top of this. It'll crush the economy. We can't have the care management approach today, which is get a folder and copy lots of pages so you could do care coordination. We're just going to grow tired of this. So we will see some of the incumbents struggle. We will see new entrants come into the industry. We're seeing some reformation of that already, but it's going to be hard because the size and scale of healthcare in the United States is just tremendous. But we're on the right path. It's like if you and I said, look, we want to improve our health, personally, what would you do? You wouldn't do anything that would make a difference in 3 months. But if you gave yourself 10 years, you could create sort of a really great version of Matt or Joe, because you'd focus on the 5 pillars of, nutrition and sleep and mindset and community and exercise. And you'd have a plan around all of those. But they might take some effort, and it's going to take the same. But we know that when you have a good outcome into the future, people do align around that, even if there is some disruption along the way.
Right. Because as you just said, framing with that long-term picture in mind, where I agree with you, you should be able to, align around that understanding that it's going to produce better outcomes and, improve the industry long-term. That can help you keep that picture in mind and hopefully work through that short-term pain. And for those of you just joining, I'm talking about Joe Gagnon from 1upHealth, and we've talked about kind of data standardization and interoperability and all the benefits. And, as I said, I'm hopeful that people recognize that that's not really disputable. But now I kind of want to pivot a little bit in terms of, as we're building in that direction, what are some of the concerns that we should keep in mind to appropriately strengthen systems and connections, especially because, as we're in healthcare, the privacy and security of data seem to be a constant risk and constant threat. And some people might even question if privacy even still exists in healthcare.
Well, we're not going to challenge HIPAA today, right? So we have to accept the way the system operates today. And so privacy and security are of paramount importance. And until the point comes when a patient authorizes the sharing of their data in a way that they feel is okay, like you share your data, as you drive across the toll, your location and your position, you've made that decision, and we need some big shift to happen before we challenge how HIPAA runs. So today, we would all want to make sure that there are 2 ways, just to be clear, how you can share data. Patient mediated, meaning patient authorizes the sharing of some data. Joe says, yes, 23andMe, you can use my data, for example. Or there's something called treatment payment operations requests, where for one of those reasons, a covered entity has the authority to then make a request because it's for a treatment reason, a payment reason, or an operation reason. And so you can make a bulk request for that data against the roster where you have the legitimate reason to be able to do that. And these are all governed by business associate agreements, and there is a lot of infrastructure. And so we're going to continue, all of us, to leverage and use those methods to make sure the data is secure and shared appropriately. The question longer term is, can we get better health if we shared our data more regularly? I think there's some thesis that would say yes. In an AI world, or sometimes in this world where we, anonymize the data, there are ways that we could benefit. Because, in your small community and only against yourself, you only see a limited view. But we have some work to do to figure that out and how that would work effectively without any bad actors abusing the system. And so as we build out this infrastructure, the reliability matters, because once you start to count on this data, it really matters. The performance characteristics really matter. The security really matters. So the ability to understand, we call it provenance, where this data came from, so we would actually know what we're doing with it. So there is a lot of sophistication in doing this, but Matt, there's a ton of sophistication that sits behind every system that we sort of interact with every day. Order something on Amazon, and the next thing you know, you're getting a text message from Federal Express that the package is going to be on your doorstep, and then you get a photo that it's there, and then all the integrated supply chain and logistics stuff is about data flow, right? That data flow is from a payment operator to a a logistics operator to a retailer to like all those things, we've proven this can work. And so we're just bringing a lot of those concepts to healthcare. It's, a little bit late to the game, but I remain hopeful.
Yeah, and I think as you're describing it, it's, and that last point you made, which is, it has happened in other places. That means it's possible to potentially replicate it. We just need to figure out how do we most appropriately build it out and adapt it for healthcare. Because it's, it is easy, kind of the flip response is to say, oh, well, healthcare is different, so it has to, operate differently. To some degree that is true because, you have different sensitivity, but that doesn't mean you can't learn lessons and evolve, systems that worked in other industries to what might, drive success within healthcare.
Yeah. Well, look, our financial data, we don't want that shared anywhere that it shouldn't be shared. And so we live in a world though where you can go to an ATM that's taking money out of a different bank. We can use, Plaid to be able to make a query on data. There are a lot of systems who have evolved appropriately there. I think, look, at the end of the day in healthcare, what we're all going to sort of want to have happen is this: we're changing our idea of life. It's not just about lifespan, how long we live. It's about how well we live, called health span. And the only way to get good health span is to actually be more intimate with the data about you, about the services you get, the cost of doing that, the way that it evolves over time. And the only way to do that better is with data. There is no other way. The individual cannot, in their minds, keep it all together. My simplest example I give everyone all the time is, the general principle now is that when you turn 45, you should get a colonoscopy or use Cologuard to check out if you have colon cancer. Well, most people don't even know that at 45. The doctor's office doesn't keep track of who's 45. The payer barely has any memory of this. But you know what? The data always knows that. It knows what your birthday is. And when you turn 45, you should just get a text message from your provider that says, hey, by the way, you've been authorized for Cologuard. It's showing up on your doorstep tomorrow. Or you've been authorized for the colonoscopy and there's an appointment next week at the doctor down the street. And it looks like from your calendar, you're available, right? And you would then actually get another text with, here are the directions on how to get there. Here's the stuff that you need to take. And then as you leave, it would get a text that says, by the way, your record's been updated. You're all good, clear. Take one in 5 years. Like the data would run that entirety of something that, look, the providers, they've thought this out. They understand that. But the data then actually helps regulate the way that all these services can be delivered. That's how we can scale better care. And that's how we can get the health span over time so that we actually know the decisions we should make that are better for us medium to long term, because we don't want the bad stuff happening to us, but we need to know more about how to prevent that. And this is just one element of that.
Yeah, so kind of if we're thinking about that picture, which brings us back to the point you were making earlier, we need to keep that long-term benefit and the long-term enhancement in mind. What are some of the immediate steps you feel should be taken or changes that should be driven that are going to keep the ball advancing down the road to that ultimate end goal?
Yeah, I think that we have to get over the idea that sharing data is, not natural, right? So payer, provider, patient, the sharing of data between the three sort of stakeholders here has to be the priority, not sort of the obstacle. So that's first and foremost. Then the second thing, so if that's your principle, then you're like, okay, well, how would I do that? And the second part is then let's do it in the cloud, because that's the best, most secure, most scalable, most performant way to do that. A lot of healthcare data is not in the cloud. Let's just make this moment the time to go to the cloud. Then the third part of this is then get the benefits defined for each of the parties. The payer can get paid what they're supposed to, the provider should, and the patient should get better service. Let's define the benefits for each of the constituents here. And then the last part of this is then let's continue to make an earnest effort to work together to overcome the constraints that are there. The constraints of old technology, of old business models, because really at the end of the day, we have to go back to the reason why healthcare exists is to take care of each and every one of us. The doctor is a patient as much as the nurses, as much as you and I are, right? And so we can't forget that that's really why we have this entire system running, even if there's a lot of system that's in the way. But if we take those steps and we do this in a standards-based way, then maybe in 5 years, we will see a market difference. In 10 years, it will be a material difference. This is what's happened over and over again. This is not actually new thinking. This is actually just getting to sort of the next of the last industries that just needs to transform. And it's fun to get to do that because this one really matters, Matt. I mean, this is where you have like real purpose in life when you get to work on this.
Yeah, and you raised a very important point there, which is ultimately this is going to hopefully improve and drive better patient care, which I think we all need to maybe sometimes remind ourselves, but should be kind of the central focus of healthcare. But do you think that the industry is going to be able to kind of drive that by itself, or do you think there's going to be kind of further government carrots and or sticks, or maybe some combination, which is probably the ultimate reality?
Yeah, I don't think we're going to keep the momentum going without the federal government. So we're sort of fortunate in this way. But if you think about, I mean, we wouldn't have seatbelts in cars if it was not for the federal government. There are a lot of times where, we're not our best friend, We need a little bit of like, okay, Joe, don't do it this way, do it that way. You're like, oh, yeah. That's the right way to do it. And so it's good to have sort of this third party looking out for our best interests in this instance. And then it sort of should set a fire, unintended here, in the industry that says, oh my gosh, this is massive opportunity for me because if I do this better, I can actually be more competitive. I can provide better services with better quality, better care at a lower cost. And I should be able to do better. My shareholders should love me, So I do think it's going to open up opportunities for the disruptors to take sort of the mantle. And the laggards get distanced in every industry. So it's nice to have the catalyst with the federal government. I'm seeing more and more customers who are thinking more boldly. I think if we talk to the members, the patients, the customer, whatever we call ourselves, more frequently, we'll hear what they want. And then it's an execution problem. And sure, that's hard work. But look, that's what we're here to do, not just 1upHealth, but the rest of us. And so, yeah, some of us have to sort of champion this, but we'll share the success stories. And in that, we'll start to get people really excited about the possibilities.
Yeah, no, and that is a great way to frame it. As you said, it's going to be challenging, but if we can promote the successes and drive awareness around that should hopefully create a snowball effect. And unfortunately, we're already out of time, so I think that's a great way to be able to wrap up the conversation. So I want to thank my guest Joe Gagnon for a great conversation today.
Matt, thanks so much for having me. I really appreciate it.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.